Suboptimal. I think we've had this 80% goal for a very long time, but we've kind of almost there, but not fully there, like 76%, 79%. And depending on where you're looking, those screening rates are very variable. I think risk factors, thinking about family history is very important. We have many different choices for colon cancer screening. We have non-invasive and invasive testing. I'm a gastroenterologist, so I'm going to say colonoscopy for everything, but not everyone needs a colonoscopy. And what we say is the best test is a test that gets done. However, if someone has a family history and a first-degree relative, then that person should have a colonoscopy, and they may not be appropriate for non-invasive screening, such as stool-based testing. They're used in average risk screening. Someone who's 45 who has no symptoms whatsoever who comes in for screening can use stool-based testing. If someone comes in and they have rectal bleeding, abdominal pain, weight loss, or any kind of alarm symptoms, that person should have a colonoscopy. That's an interesting question. It's hard. I think there are different barriers. It's multifactorial. I think access in some cases, I think understanding, and patients can be scared. I think knowledge is important. Some people may not realize they have risk factors, and a lot of our patients don't have a family history or they don't know their family history. But I think a lot of it is just knowledge. And I think as physicians, we really need to take the time to have a conversation with our patients around screening, why it's indicated, and the benefits of screening for colon cancer. So there is no one right answer to that question. It's a multifactorial. If you're looking at system-level interventions, what has been shown in randomized controlled trials is patient navigation and screening outreach, meaning, or mailed outreach, meaning I'm going to mail you a fit test, I'm going to mail you a letter of invitation. Those things have been proven to increase screening rates, specifically in vulnerable populations. Well, the blood-based testing is exciting. It's simple, it's quick, but everything has a pro and a con, and I think we have to figure out where does that fit in the paradigm. Does colonoscopy right now are used for screening? Do we go to colonoscopy in a diagnostic test and do non-invasive testing? Do we keep colonoscopy as a first-line choice? And within the United States, we do opportunistic screening, meaning you go to your primary care doctor, you have a conversation, you decide to do colonoscopy. In other countries, they actually do more organized screening where they may do stool-based testing as a first line, whereas here we do stool-based testing and colonoscopy as first line. So I think there's a lot that can happen, and maybe thinking about precision medicine, meaning tailoring screening to that particular patient, may be something important to look into. There are different models that we can look at risk factors for individual patients. Say your average risk based on you're 45, you have no family history, but there are ways we can calculate your risk score, and maybe you have a higher risk score compared to someone else, so you get a colonoscopy, but someone else who has a lower risk score gets a stool-based test. There's a lot of things that can be done. With to see what the future holds.